Good evening, everyone. Welcome to our April Journal Club. We're honored to have Dr. Russell Boston, who is a PGY1 at Atrium Health Carolinas Medical Center. Dr. Boston graduated from PCOM, and his interests include spinal cord injury, sports medicine, MSK ultrasound, OMT, and medical fitness. He is passionate about sharing all that PM&R has to offer and is a wonderful resource for anyone that's interested in this specialty. So, welcome, Dr. Boston, and thank you for speaking to us today.
Yeah, no, appreciate it. Happy to be on. I'm here with Dr. Nathan Dargy. He is one of our brain injury attendings. I actually got to work with him for the first time back on my elective months, and we had a nice little week together. It was fun. So, Dr. Darcy, if you just want to give a brief intro, say hi real quick to everyone in the chat.
Hey everyone, happy to be here. And yes, I had a great week with Russell back a few months ago and excited to see what he's got in store for us today.
All right. So yeah, the article I chose, it's like a proof of concept study. It's called Innovative Management of Spastic Shoulder Contractures, a retrospective cohort analysis of combined percutaneous cryoneurolysis and tenotomy. And I kind of chose it because I was at the AOCPMR annual meeting a few weeks ago, and that was the first time I had really heard and seen of kind of what cryoneurolysis was. So I was like, huh, might as well find an article on it and learn some more about it. So let's go ahead and get right into it. Go next slide. Perfect. So first, just, setting some of the framework here, what's spasticity, what's a contracture, what is this spastic contracture thing, and, why do we care about it as rehab physicians? As some of you probably know, or at least have heard of, spasticity is like an abnormal velocity-dependent increase in like our stretch reflex that results after various types of damage to the central nervous system. Whereas contractures, on the other hand, are more specifically musculoskeletal, actually referring to loss of range of motion caused by, shortening and fibrosis of our muscles, tendons, ligaments, the joint capsules, all the soft tissues. And they're not, exclusively independent. There's been this kind of self-reinforcing triad of a spastic contracture that has been described, and essentially the three components are, you have an injury to your CNS that damages some of those descending inhibitory signals that you have and can lead to abnormal activation of some of these alternate pathways that essentially leads your spinal reflex arcs to become hyperexcitable and you get involuntary muscle activation. Um, with this, you also have the combination of spinal plasticity, which essentially, normally when your spinal reflex arcs are going, the spine itself normally has a process to dampen down the repeated firing signals, but it loses those. And because you have these involuntary contractions, sometimes these limbs for patients can get stuck in certain positions or this postural hypertonia, as we talk about. And the combination of those two can accelerate passive tissue remodeling. So you can imagine you have these muscles that are stuck, contracted, they're in certain positions, and that leads to loss of your sarcomeres, loss of your myofibrils, fibrosis of the muscles and tendons, and eventually what can lead to contractures. So why do we care about it as rehab physicians? Because this severe spasticity and contractures, they lead to pain, loss of range of motion, skin breakdown, and for our patients, this means loss of their independence, decreased quality of life when they're working through their rehab, right? It limits the amount of functional recovery they can have, and it can increase healthcare costs. There's been studies showing that, patients going through brain injury rehab, with those in spasticity versus those without spasticity, those in spasticity, their care can cost up to 4 times, the amount. Next slide. So kind of traditional treatments that we have for put in here for the spastic shoulder contractions, but really for spasticity in general. First line is our non-pharmacologic stuff. This is what we often rely heavily on our therapy colleagues, exercise physiology colleagues for stretching, range of motion exercises, seriocasting, breathing orthotics, and sometimes electrical stimulation, especially if patients still have, some degree of voluntary motion in those extremities. When we're talking about more focal spasticity management, um, Botulinum toxin is the one you will always hear about most often, very commonly used, best for spasticity, not so much for contracted limbs, but there are some limitations, right? The FDA determines max dosing limits for specific muscles, and in some patients, they would need above that approved dose to get the sufficient response and reduction in their spasticity. And in some people, botulinum toxin over time, the effect can diminish. When we're talking about potentially a more global spasticity picture, this is when a lot of your medications, come into play, baclofen, methocarbamol, or Robaxin, and then tizanidine. Problem with medications is, you have to watch out for side effects. So all of them can be sedating. Baclofen, especially in patients with kidney dysfunction, and tizanidine can also, lower blood pressure. You got to worry about, orthostasis. So those are things you have to contend with from that standpoint. And then classically, once you start to get to, real severe spasticity, thinking about contractures, this is when surgical intervention, starts to come into play. We're thinking, does somebody need a baclofen pump? Does somebody need tendon lengthening? Does somebody need a neurectomy or a variety of other procedures? That can be pursued. But again, all these are invasive, and anytime you go under the knife, it comes with risk. Go ahead, next slide. And here, just something to look at if we share these slides after, but just some of the common things that are used in spasticity management. I've highlighted a lot of things that I've seen used and used pretty consistently. So more so just for, your education if you want to look over it. Go ahead and go to the next slide. Cool. So now kind of setting the stage here for what the article is going to get into. So what is cryoneurolysis and what is tenotomy? Cryoneurolysis is essentially very targeted application of extremely cold temperature to your motor nerves. And what this is going to do, the way it's applied, is cause Wallerian degeneration, or essentially just degeneration of the axon, while leaving the surrounding tissue around the nerve intact. And what this does, since you have the surrounding tissue, will allow the axon to regenerate over time. So the effects are reversible. So it's not like a permanent thing, like a surgical intervention. However, you do get a good duration of effects, commonly reported from 3 to 6 months, but it can last, in some patients, a year or even more, which is much longer than, say, botulinum toxin. And also, there's no treatment limit, right? You can do as many nerves as necessary in one treatment. And there have really been minimal to no adverse events reported with its use. Now, what is percutaneous tenotomy? It's essentially a minimally invasive procedure where you find a tightened or contracted tendon and you go under ultrasound guidance and you essentially use a needle perpendicular to it to try to release it and gain some more range of motion. You see there some of the common sites that it is used, and it's been shown to be pretty effective for patients. And we're thinking about how I talked about kind of the mechanisms behind spasticity, contracture, kind of the whole basis of this article is approaching the treatment from, a mechanistic standpoint, trying to combine cryoneurolysis to target the nerve or the neural aspect of the spasticity with tenotomy and the structural MSK component of the contracture. Go ahead, next slide. Perfect. So moving on to the study here. It's a single center retrospective cohort study out of Canada, I believe, PMR department at University of British Columbia. Primary objective was to evaluate the combined effects and the sequencing of cryoneurolysis and pectinotomy on one spasticity measured by the modified Ashworth scale and passive range of motion in patients with this refractory shoulder spasticity and confirmed contracture. And then their secondary objective was to assess actually whether the addition of pectinotomy in addition to the cryoneurolysis substantially improved their outcomes. You can see off that snapshot on the table to the right, the population and some of the inclusion exclusion criteria. Everyone was over 19 years old, had to have refractory shoulder spasticity, meaning that they would have had to fail botulinum toxin before a pec tendon contracture confirmed by a palpation, and throughout the course of their treatment, they had to obviously have been treated with cryoneurolysis and tenotomy. And prior to the cryoneurolysis, they had to have a diagnostic nerve block with lidocaine ahead of time and responded well to that. And then some of the exclusion criteria: couldn't have prior surgery to the target location and no botulinum toxin within the last 4 months to make sure that none of the effects that they were seeing in the patients was due to the botulinum toxin. And the general sequence for how the patients were treated was the initial evaluation, testing their spasticity, testing their passive range of motion. They would do the diagnostic nerve block with the lidocaine, looking for improvement in spasticity, and passive range of motion temporarily, just showing that the lidocaine worked, they were in the right target. And then after that, they did cryoneurolysis to the lateral and median pectoral nerves. After that, they did a reevaluation of spasticity, passive range of motion, and if there was what they described as a hard end feel and palpating, that pec tendon that felt contracted, then they went ahead and did the needle tenotomy. So let's go kind of into the results of the study and see what they found. So first, what I'm looking at here, we just see looking at passive range of motion, and this is just the effect after the combined treatment. So after they had had both their cryoneurolysis and their tenotomy. You can see some of the details of the statistics there, but what I have highlighted here in green is that both for shoulder flexion and shoulder abduction, there were significant improvements in the passive range of motion after their full treatment course with pretty good effect sizes. Now, external rotation, not really a statistically significant improvement, but you do see this medium effect size here. So potentially did patients gain some passive range of motion in external rotation? Possibly, but just from a statistical standpoint, it wasn't a significant amount. Next slide. Excellent. And now we're looking at, how did spasticity change, and we're looking over different time points over the course of their treatment. So starting on the far left where you see baseline and after all treatments, that's essentially comparing their spasticity from, day one, the very beginning, to after all their treatments. The second column that you see there is baseline and then right after the cryoneurolysis treatment. And then the third, where you see after cryoneurolysis and before tenotomy. So many of the patients in this cohort had their cryoneurolysis and tenotomy as separate sessions. So this is basically just looking at, how their changes in spasticity, or if there were any changes between the treatments. And then finally, you have the fourth column that says after cryoneurolysis and after tenotomy. And this is essentially, they've got the cryoneurolysis, they've come back, now they're getting their tenotomy. Was there, any additional benefit to their spasticity? So going back to the first column here, the baseline after all treatments, similar to what we saw with passive range of motion on the last slide. Significant difference in mostly flexion and abduction, but also external rotation. And then moving on to the second column, you see right after cryoneurolysis, so flexion had a statistically significant increase, or I should say improvement in their spasticity. And although abduction and external rotation didn't quite meet statistical significance, they were very close. So you can kind of say that, okay, they probably, had a decent improvement clinically, and their spasticity just didn't quite meet statistical significance. And then in the third column here that you see after their cryoneurolysis and then right before they had their tenotomy, you do not see a statistically significant difference. And I highlighted that part in green because that's basically showing us that, hey, whatever improvement in spasticity that they had after they got their cryoneurolysis, it didn't really wane in the interim, which is what you would be, looking for after that treatment. And then in the fourth column, they got their cryoneurolysis, they come back, they got their tenotomy, and you didn't really see a statistically significant difference in their spasticity, which honestly is to be expected because if you remember what I talked about before, the tenotomy is more so after the contraction, the musculoskeletal component, not so much the neurologic spasticity component. Go to the next slide. All right, so next, going back, looking at passive range of motion, just broken down by the same time point, so same columns and setup, and going baseline after comparing their baseline to after all of their treatments, similar to what we saw 2 slides ago, right? Significant improvements in passive range of motion for flexion and abduction, not so much for external rotation. And second column, just comparing their baseline to immediately after their cryoneurolysis treatment. And you see kind of the same thing there, which maybe can imply that a lot of the benefit that they had was due to the cryoneurolysis, but we'll talk about that more in the discussion. And then here in this third column, after the cryoneurolysis and their evaluation right before they got their tenotomy, interestingly, they had a loss, and some patients had a significant loss in shoulder abduction. Authors didn't really give a good explanation as to why, and I don't particularly have a good explanation as to why, but I thought it was just, an interesting data point to note. And then finally, over in this last column here, you have after they got their cryoneurolysis, and then finally after they came back and got their tenotomy, really no statistically significant difference in their passive range of motion. So did the tenotomy really help? At least from a statistical standpoint, you can't really say that it did. All right, perfect. So, moving into the discussion and conclusions for the article here. So, looking at patients with refractory shoulder spasticity and confirmed contracture, they did the sequence of the diagnostic nerve block, the cryoneurolysis, reevaluation, and tenotomy. Overall, in patients, did have some improvements in passive range of motion and spasticity. More so, it seemed, with flexion and abduction, not so much external rotation. They also did show that it was safe. There were no adverse events reported with the patients who received cryoneurolysis. One patient who got tenotomy did have a hematoma, but they were on a blood thinner, which was not known ahead of time, but the hematoma self-resolved after 10 days without any lasting effects. And as I kind of alluded to on the last slide, it seemed that a lot of the improvements, both in the spasticity and passive range of motion, were driven by cryoneurolysis as opposed to the addition of tenotomy. And you'll see below when I talk about some of the time between treatments that it seems like the effects may last months, even up to a year, which would be, consistent with some of the other data that's out there. But limitations of the study, it's going to have a lot. Obviously, it's a small cohort proof of concept type study. So single center, there were 15 people, 16 shoulders. So somebody got both shoulders done. And a small sample like that makes it hard for the study to truly evaluate the effects of tenotomy independently, especially since they only did the sequence with tenotomy right after cryoneurolysis. Additionally, it was a retrospective design, not a trial, so there's no control group that we can compare against. So we have, these statistically significant or insignificant findings, but nothing to compare to. So don't really know in general how helpful any of this was. They only did the shoulder. There's been more data published out there about, doing cryoneurolysis and other joints of the upper extremities, lower extremities. So pretty limited from that standpoint. And then I think some of the biggest limitations for this study, which the authors also touched on, but I'll just expand upon, were that even though they had this treatment sequence, the execution of it was pretty heterogeneous between the patients, and there wasn't a lot of just breaking down of the data between them. They still kind of grouped everyone together. So like 4 out of the 15 patients got cryoneurolysis and tenotomy on the same day, where the other 11, there was a mean of 410 days between the cryoneurolysis and tenotomy. Why? Because the range of days between treatments was absolutely insane. It goes from just under a month and a half to over 2,000 days, which is a very wide range and definitely adds some confounders to any interpretation of this data. And then, as I'll show you on the table on the next slide, all patients did receive cryoneurolysis to additional nerves other than the pectoral nerve, which certainly can affect, what we would expect to see with spasticity and passive range of motion of the shoulder. And then lastly, thinking from a more holistic physiatry perspective, it's very limited. They were just looking at passive range of motion and spasticity. So there were no functional outcomes, right? We're not talking about quality of life. Were they able to do hygiene better? Did it take any burden off the caregivers? Did it improve patients' pain? Some of the things I had talked about earlier in the presentation about, why we care about managing spasticity, late stage spasticity, and, these contractures. The next slide. Perfect. So here you can see how different treatment was for many of the patients, right? So everyone got lateral pectoral nerve. 14 out of 16 shoulders got median pectoral nerve, but then you're looking at things like suprascapular nerve, subscap, thoracodorsal, musculocutaneous, axillary nerve. A lot of these nerves that can innervate muscles that directly impact, what you can do with the shoulder from a flexion, external rotation, and abduction standpoint. So when you have a data set, that's this heterogeneous and not standardized, obviously it wasn't a trial as we talked about, but does make it hard to interpret some of the data, especially when you're already looking retrospective and you have a small cohort, as this study did. And next, thank you. So, kind of just overall clinical approach. How does this apply in PM&R and just kind of my initial thoughts? I think still the idea of treating, spastic contracture through a mechanism-based approach does seem logical. Cryoneurolysis addressing the neurospastic component with tenotomy, going after more of the structural component. More data is definitely needed to see if tenotomy, in addition to cryoneurolysis, has a role because it's been proven to have some benefit on its own. Cryoneurolysis in itself may be useful in patients who are refractory to botulinum toxin and who may either not want to or may not be great surgical candidates and don't want to take that risk. And Tenotomy in itself, as I was alluding to earlier, there just needs to be more studies on it in addition to cryoneurolysis, because as it seems right now, at least from this limited cohort, seems like cryoneurolysis was doing a lot of the heavy lifting with improving spasticity and passive range of motion. But I do think a big point, a big takeaway from this is that, cryoneurolysis is as effective as it's shown to possibly be in this proof of concept study. And I think anybody who's, managing spasticity as part of their practice should either be trained in or at least have a referral to a center or another provider who offers cryoneurolysis because, as I was alluding to, much lower risk than surgery, has had some great outcomes. And if any of you were at the AOCPMR annual meeting, one of the authors of this, Dr. Paul Winston, he did a great presentation and had a lot of videos on patients who had undergone cryoneurolysis, and the results were pretty incredible. So there you go. Next slide. Thank you all. References are last. And I am open to taking any questions.
You can go ahead and unmute yourself and ask.
Okay, just wanted to make sure. Yes, how are you doing? My name is Marquis Flood. I'm a rising M2 at PCOM.
Well, I
So
know
one of
who you
the,
are.
I know you do. I just wanted to do it for for everybody else that's here online. I may have missed it in the slide. Um,
Yeah.
but is there any form of therapy that is needed after having this procedure done?
Yeah, so it wasn't specifically addressed in this article, and Dr. Jargi, you can tune into, but at least from what I've seen and what I know, typically is getting back to whatever normal life physical therapy, occupational therapy that they've needed to do or haven't been able to do because
Okay.
their spasticity or their contracture has been limiting them. So whether it's like gait training or trying to work on more of these like larger gross motor movements to be able to help with things like hygiene or picking up things or whatever.
Okay. Thank you so much.
Hmm.
Yeah, just to kind of piggyback off of that, there's actually not a lot of literature on what we should be doing after botulinum toxin treatment for or a spasticity treatment period with therapy. So there's actually a lot of heterogeneity, and I experience this in my practice a lot. Is I send a patient to therapy after I do toxin or phenol or whatever it is that I'm doing, and each therapist will do something different. I personally believe, and I have a strong relationship with some of the top therapists in our department, that I think functional electrical stimulation is really key because now once you reduce the spasticity, now we need to stimulate and provide that proprioceptive neural feedback to the brain to for ongoing motor recovery, right? And a problem with a lot of these spasticity studies, and Dr. Boston, you may have alluded to this, but is that we don't look at a lot of functional outcomes in spasticity treatment. We're always looking at MAS. And if you look at all of the clinical trials for Botox and Dysport and Xeomin and all the botulinum toxin products, we always focus on MAS. And that's kind of somewhat necessary to get FDA approval for some of these, interventions. But it's not always the outcome that we're looking for that patients are looking for. They're not patient-centered outcomes, right? What is their quality of life? What is their function? What is their motor return? Does reducing spasticity help with motor return? I believe it does, but I think it has to be paired with an intervention like functional electrical stimulation and constraint-induced movement therapy, those type of things, in order to really maximize the benefit of your spasticity treatment. So, spasticity treatment is only going to be as good as the therapy and the carryover that follows the treatment plan.
That makes sense. Thank you so much.
Elizabeth, you can go ahead.
Yeah, thanks so much for the presentation tonight. It was a really good article. And for everyone, I'm Elizabeth. I'm finishing up my third year at Campbell University School of Osteopathic Medicine in North Carolina. And so with cryoneurolysis being reversible, and I know for the paper there was like heterogeneity with the tenotomy dates, but do you guys think that with cryoneurolysis being reversible, do you think the tenotomy procedure would be more beneficial once that spasticity returns? Like, do you think if they did a more rigorous, more rigorous study to figure out tenotomy, do you think it would have a better effect than the paper showed?
Yeah, that's a good question. I honestly don't know. If I could, take a guess at it, I think it would depend on one, how severely they were limited, and then after they do the cryoneurolysis, do they actually have evidence of, contracture or contracted limb? Because if we're more so just like in the earlier stages of spasticity, not necessarily of contracture and having those structural changes, then I don't see as big of a role for tenotomy in improving, their range, their outcomes. So I think it more so just depends. Dr. Garzi, if you have other thoughts or experience on that.
Yeah, I think a lot of it has to do with the differentiation between the neural and the non-neural components, right? And so I think the clinical takeaway from this article is honestly that we should be doing diagnostic lidocaine blocks to figure that out and to help with the treatment planning, right? And so if you do, let's say you have a patient that comes in with a spastic shoulder and you do a diagnostic lidocaine block to the medial pectoral nerve, so you're targeting the pec major, and you notice some improvement in the range of motion, but there's still kind of a hard end feel, right? Then that tells you that there's both a neural and a non-neural component. And so that patient may be amenable to both cryo or a nerve-targeted intervention coupled with tenotomy, versus a patient that just gets like almost full range of motion with the diagnostic lidocaine block. That tells you that that's mostly neural based and that tenotomy may not be helpful, versus a patient who gets very minimal range of motion improvement or MAS reduction with a diagnostic lidocaine block. That's mostly a non-neural component, right? And so then you focus on the contracture management from that standpoint. So that's how I look at it. From an algorithmic perspective, is really trying to differentiate between neural and non-neural components. And I think we try to do that. I think physiatrists, we try to do that without doing the lidocaine blocks, and we're actually not very good at differentiating them clinically on an exam. I've had patients come in who are stuck in elbow flexion, and it looks like it's a contracture. I thought it's a contracture. I would bet $1,000 that it was a contracture. I do a diagnostic lidocaine block, and you get full range of motion improvement, and it's not a contracture. So, so you have patients that look like contractures that are not contractures, and I think that's the utility of the diagnostic lidocaine block. And I've heard Paul Winston talk about this a lot, and he's a big advocate of it. And I don't do diagnostic lidocaine blocks as frequently as I probably should, but I think it's a really helpful tool in differentiating the neural and the non-neural components of the reduction or the range of motion limitation that the patient is experiencing. I don't know if that was your question, but I talked a lot and I hope I answered it.
Yeah, that was great. Thank you. I actually had a follow-up. So for cryo and the presentation I saw at AOCPMR was great. And with it being a more newer kind of procedure, is this a like a senior thing in a residency or residency programs adding it to the curriculums? Do you guys know, or is this more like a continuing education procedure you learn as an attending?
It is
I
really it's spreading. It's spreading a lot actually. At our institution, we have purchased the
yeah.
device. We have the device on hand. We have everything on hand. The only thing that's left is for me to take a course so I can learn how to do it. But I do phenol, so it's very similar to the nerve targeted procedure that I already do. But I think in most places where you go, you will. I think it's starting at least the big academic centers. It's I think already pretty much there in the U.S. So I think more and more programs are starting to incorporate it into their practice. But and it depends, and there are certain clinicians that are still hesitant. It does require like there's a learning curve for people that don't do nerve targeted procedures. You have to learn the nerve targets. You have to be comfortable with ultrasound. You have to be comfortable with, using the device and things like that. And the other thing I've heard a lot is that it can be very painful,
Mm.
and it can take a lot of time. And so those are kind of the drawbacks from people like using it more consistently. I think botulinum toxin is still like favored as like the mainstay treatment option. But I will say cryoneurolysis is a very hot topic right now, and it's spreading like wildfire throughout the world, honestly, throughout the world. So people are really excited about it because it's something new and it's something different, and it's providing some good outcomes for the people that are receiving that treatment option.
Great, thank you.
Does anyone have any other questions? It can be about the article or just about residency or anything like that. Alrighty. Well, thank you so much.
Hold on. I think we
Sorry,
got
we got one.
one in the chat from Ariana said, I don't know if this was Jess, how many sessions are normally appropriate for patients? Hmm, that I'm not sure. My answer would probably say it depends. I don't have obviously a lot of clinical experience with cryoneurolysis, but
Yeah, my understanding is, again, I also don't have
yeah.
clinical experience with cryoneurolysis. Dr. Boston. We're on the same page there. But I think my understanding is that if you're gonna target low, so let's say you're gonna do one nerve, you should probably hit the nerve at different levels, like at least a few different levels. So let's say you're gonna do like three nerves in that one session, then you're probably going to be poking the patient like 9 times, right? Um, so it just depends and on how much you're willing to do in one session because it can be very time consuming. I think for me, when I first start doing this, I'm probably going to target 1 to 2 nerves per session because I'm not going to have that. I'm not going to have an hour and a half to 2 hours to sit there and do a procedure in my clinic. And you may have to bring the patient back to do additional nerves if needed or if you want. Um, I think the question about how long it lasts is an interesting question. I believe I saw a LinkedIn post by Paul Winston recently. I think he said on average it lasts like he had some patients that it lasts like 18 months or something like that. So nerve targeted procedures in general last much longer than botulinum toxin. When I do phenol, it lasts a lot longer, several months. And so if you get an effective response, you may not have to do it again for a very long time, which is good because then the patient doesn't have to come back.
I have a question. So when you have a patient that has a contracture over spasticity, how do you typically treat that?
If they have contracture and not spasticity,
Yeah, or more so
it's
than spasticity.
yeah, at that point it's typically a surgical intervention. You're usually referring to a orthopedic surgeon to help address that with tendon lengthening or other orthopedic interventions. And a lot of times, sometimes orthopedic surgeons will want you to do all these things before they come to them, before, the patients come for surgical interventions. Sometimes they'll say, "Oh, keep doing toxin or try this or try that," or and before they get to that point.
Thank you.
Hmm.
Any other questions? Alrighty, well, thank you guys for coming today, and thank you, Dr. Boston and Darji, for coming. We appreciate it.
Of course.
Absolutely.
Thanks,
Yeah.
guys.
Appreciate the opportunity.
See ya.
See you.